so it was gratifying to hear that, that in your division, you actually now have a driver officer who's doing some of the work, so that it's not just talking about it, but it's actually doing it, So how have you found that, have you found it useful so far?
I would say it's been incredibly useful. So I'll just give some specific examples. You heard someone from Baiji speak earlier. So we have clinical trials that we've partnered with them on a national clinical trial where I was involved in the steering committee. The clinical trial helped to change the eligibility criteria for that clinical trial before it got launched internationally. And then now that it's launched and enrolling, one of the things that has been a little bit of a challenge is enrollment within the United States and enrollment within particular patient populations. Chijoki has helped with the network that you saw to open up that clinical trial at LBJ at our county hospital to enhance enrollment there, to promote enrollment at many of those other sites, some of which were able to open the trial and others that weren't, and then now is launching that at a new site that's an MD Anderson partner, the Ochsner Clinic in New Orleans, which also will help to enhance enrollment and to increase the representativeness of the clinical trial. And so I think those are just putting those kinds of things into action. Likewise, I mentioned that the initiatives that we did with the development of eligibility criteria, those have now been implemented. We're on our third clinical trial in frontline diffuse large B-cell lymphoma that where members of us that sit across the LEO network have sat on steering committees and refined the eligibility criteria based on those efforts.
So Matt, you said something that was really very impactful, right? That is us really looking at ourselves. And this question of implicit bias is not a thing that is only present in white people. It's in all of us. It's the way we are wired as human beings, and how do we look at ourselves and be able to identify those things that we know are probably not right, and then adjust our behavior appropriately. And so when you're talking to mentees in your institution, is this something you're encouraging them to do? And how do you do this without coming off as this very woke physician who's trying to get everybody to be woke?
I try to reframe, and so I get the opportunity for fellows to be in my clinic for about 3 to 4 months, right? And they get it, in some ways, I give them a pass for about the first week. But my goal is to massage them as humans first, then clinicians second. And how do you do that? Well, you give them the opportunity to present in front of you, just like you're their med student or an intern, and craft their presentation. And come back to this. They get annoyed with me because I'll ask them, where are they from? What's their occupation? Who's with them? Do they have kids? And they're like, I don't know. And after the first week of I don't knows, the second week is when I get critical, right? Because did you learn from what I think is incredibly important to help craft the story, to craft the plan of how we are going to treat this individual? Okay? And the second week, if they're not reporting back to me, they're from North Platte, Nebraska. They work for Union Pacific. They're a diesel engineer. They're married. They have 2 kids. The oldest kid is with them. Their highest level of education with high school. Because what does that give us the ability to do? To frame something incredibly complex to them as a person, as an individual. To tell them how you want to help them in their words. We don't teach that anymore. by the end of their 4 months, their social history is the best social history in the electronic medical record. We can't continue garbage in, garbage out in our EMR. We need to be intentional in what we put in there to help move this forward.
Great answer. Questions from, Dr. Guerra.
Hi, Carmen Guerra from University of Pennsylvania. I really, many of the things you said, Dr. Lunning, resonated with me, and one of which is the implicit bias response that you just had. At the root of implicit bias is a dehumanization of some individuals compared to others, and people become either a disease or a representation of who's an ideal clinical trial participant and who's not, without exploring the humanity. I also had some thoughts about your comment about socioeconomic status, and I'm a little old, so I kind of remember this from 20-something years ago when the American Psychological Association had a national campaign to collect this data, and I wonder if we can learn some lessons from them. It was called Stop Skipping Class. Stop Skipping Class. And they provided a series of recommendations for us to collect that information: income, occupation, household size, and to use it because it explains so much of the differences we see clinically, but also if you know the answers to that, that information can be used to allow individuals and families to access services that they might not know they might be able to access. And so I wonder, in posing this question to the whole community here, is maybe we need our own Stop Skipping Class movement.
Stop skipping chemo. Right? I mean, but this is what I love about this meeting, right? I mean, this is the impetus for what is the next 48 hours of open dialogue, and Dr. Biharé is always the first guy to the microphone at ASH, right? So, and asking the most intriguing question. But I want to double click on that a little bit because, I think that you're absolutely right. Like we are skipping, some of what can be one of the most important drivers, unfortunately, in our health system around how to move forward the discussion. Let me give you a quick example. CAR T cells, right? I don't know. I know what their name is. I can assume how they identify themselves by gender before I walk in the room. But what's the third question that I ask my CAR T cell navigator? You'll never guess. What is their insurance? Because what their insurance is in Omaha dictates the discussion that I have with them and their caregiver before I walk in the door. Why? And this is the American paradox right now that we have. If you have Medicare with a supplement, green light. Go. I see him on Tuesday, I apheresis him on Thursday. If you have Medicare with a managed plan, yellow light. Sometimes I can go, sometimes I can't. If you have Blue Cross Blue Shield of Nebraska, red light. Where is that discussion? Now, we've looked at it, and it doesn't impact the outcomes of our CAR T cell, but it significantly extends the brain-to-vein time. When I want to do the CAR T cell to when I can actually apheresis them. And the only thing that's keeping that curve together is that population that has the red light is younger, often has less comorbid conditions. They can wait sometimes, not all the time, right? But what changes in that population? Their burden of disease. And what do we know about CAR T cell? Size matters. Sorry.
Yep, that's right. Maybe just staying with the cell therapy theme. So Warren Fingret, who is a mentee and a colleague of mine at MD Anderson has taken on your question, Carmen, in the setting of cell therapy. And I think, one of the things that has been a challenge, particularly in the realm of allogeneic stem cell transplantation, is identifying and finding a donor for particular patient populations. And, his kind of take on the matter is that, with the opportunities that we now have from cord blood transplantation and haploidentical transplantation, every single patient has a potential donor. And so he's gone really deeply. He actually just got an award at the Tandem meeting for this work, really deeply into the understanding of social history to understand what are the social determinants of health that impact who's able to get through the process of allogeneic transplant. And that's absolutely driving both his research and the opportunities for patients.
Thank you. Darren Casani with Santa Fe. Thank you, Dr. Bihare, for this meeting. It's fantastic. Matt, you used the term vulnerability when you spoke earlier. And so the question, 'cause I think it's a critical term and a critical thing to embrace. So a question for both you and Chris is, as you interact with medical students or fellows, people moving through your program, how do you impress upon them the importance of being vulnerable, particularly when they're interfacing with patients? Because just because you have a bunch of alphabet behind your name doesn't mean you know everything. And to the point that you both sort of made is the information that you gather at the outset of that interaction is critical to your treatment plan and the things that you can and can't do for those patients. So being vulnerable and letting the patient know. There's a lot I don't know, so we have to work together. You have to help me become more knowledgeable about you so that then I can more effectively treat you. How do you impress that upon your students and the people moving through your program? Or is that something that you've really thought about?
You want to start?
Well, I do T-cell lymphoma, so I get comfortable with uncertainty, because starting with the diagnosis, 95% of the time it's right and 5% of the time it's wrong. And
Maybe it's more than that.
Yeah, probably, yeah. It depends upon where you're at with the hematopathologist, I suppose. But anyways, I impress upon the fact that I'm willing to say I don't know, right? There should not be shame in saying I don't know, right? And what does I don't know lead you down? Further exploration to the answer, right? And so in lowering that discussion to them when they come back to you and they're like, what do you think? And say, I don't know, right? It basically humanizes, again, since we're on that, the discussion that I may be considered the key opinion leader, the expert, the person that traveled 4 hours to come and see, but each situation to just say like that, I know the answer. I think I know part of the answer, but we need to kind of investigate that 20% that gets us to the best plan for that individual, and we may have to do some reconnaissance, right? We may need to build upon the iterative practice, because you should not be writing your note before you go in the door with what you're going to do. It's a problem but we've become so stressed in the EMR where you just think that you can pull everything in and then we forget about the patient that's in the room because my note's done before I walk in the door. That's the unfortunate culture that we've bred or are breeding into our trainees. I don't need to see the patient, I can see their lab. Gotta get out of that cycle. We gotta break that. Otherwise, we just become AI.
So Chris, last word, MD Anderson is a leading institution in the world. And so what MD Anderson does can significantly influence anything in cancer. Beyond some of the things you talked about, how else do you think we could leverage your institution?
Yeah, that's a great question. And maybe I'll talk through what we see as kind of the next generation of what I showed you. So essentially what I showed you with the LEO data set that we've done so far is we've taken trials that have already been completed and looked at what their eligibility, their criteria had impact on who could have been enrolled in that clinical trial. What I didn't show you is that the 7,700 patients that we enrolled from 2015 to 2020, we've now continued enrollment from 2021 forward, and we're in the process of enrolling about another 8,000 patients into that observational study. And now what we're doing is leveraging those data to be able to design eligibility criteria, but then to be able to look within that data set and see how those might impact the outcomes for patients, how that might impact who's eligible for patients, and then actually designing the trial based on what we know in a data-driven way. To be able to try and represent the populations we want to go on, and to be able to identify the patients with the expected worst outcomes with standard of care therapy, so that the patients that are most likely to benefit from a trial will go on to a trial. And I think that's going to help to be able to design trials in a much more efficient and better way, and to make them more strongly representative. And we're trying to move from the lymphomas to do that across all cancers.
Thank you.